Now, please welcome to the stage Dr. Martin Pham.
These have all been really great talks, and I'd like to thank everyone for the opportunity to contribute in such good company. Like Dr. Rajpal, I'm the other lonely neurosurgeon on the faculty, so we can both be the two black sheep together. The talk that I'm giving is the value of planning, which is a little bit of a shift because the focus of this talk is actually going to be on the MDT robotics platform. And so with regards to the overview, I'm going to go over what is the usual workflow for most surgeons, touch upon why you should pre-op plan, and then again touch base on the MDT software. And so as many of the talks here today have shown, the usual workflow for most surgeons deals with either navigation or fluoroassist, especially when we're talking about minimally invasive applications. And so with navigation, you spin your intra-op CT, or with fluoroassist, you bring in the C-arm and then you adjust your trajectory with the assistance of fluoroscopy. Now the thing is I call this on-the-fly intra-op doing. And so when you get and use your navigation, you spin the CT, you put everything up on the screen, and then with your instruments, which are now navigated, you look at the screen and you adjust your entry point and your trajectory on the fly in real time. So everything you're doing is utilizing that OR time to accomplish your surgical goals in that time. Now, similarly, with fluoroscopy assist, it's the same thing. You put in your Jamshidi needle, you put it down where you want it to go, and then you take a shot, you adjust, you take a shot, you adjust, you take a shot, you adjust. All of it, again, on the fly, doing it intra-op as you go. Now, we'll touch base again. These are minimally invasive applications, but the potential disadvantages, which are fairly obvious with navigation-based, this on the fly can run into troubleshooting periods of time where you're wasting that time in the OR, especially for complex anatomy, or especially if you're adopting the technology early on. There's the OR spin time, which is valuable OR time that's being utilized, as well as patient under anesthesia time. As many of you who've been trained in the use of navigation base, as I was, you hear this ringing in your ears to don't bump the navigation frame, because as many of us, myself included, have done, once you bump it and the nav is off, you have to bring in the O-arm again, spin again, and you use up that valuable OR time. The last is, of course, if the nav is accurate. So you're depending on the screen, and usually the majority of the times it is. Every once in a while, you're looking at the screen, your implant looks great, but then something, the spidey sense tells you that something doesn't feel right, or the monitoring is the neuromonitoring is off. And so there's this question about whether or not the nav is accurate, those rare instances. Fluoroassist comes on with the same disadvantages in that on-the-fly troubleshooting as you are intra-op doing. As touched based on earlier talks, there's a fluoro time for the surgeon and the patient, and then this workflow of taking all these AP and then lateral fluoroscopy shots. I will touch base on the potential disadvantages of just freehand placement in general, of which many of you are familiar with as well. Same thing, this on-the-fly troubleshooting of intra-op doing. You get your entry point, you put down your gear shift, you feel the trajectory, something doesn't feel right, so you adjust as you go in the OR. There's a potential for complex anatomy, such as revisions, fusion mass, small pedicles, and then uncommon trajectories. So for types of trajectories that aren't done as often, then there's that potential to use up even more troubleshooting time as you're putting in your S2 ALR iliac screws, cervical pedicle screws, cortical trajectory screws. But good news, there is another way. And this is where I get into pre-op planning. And so this is a very large workflow shift that I essentially had to adopt as well. Instead of this intra-op doing with navigation and fluoroassist or freehand placement, let me show you the value of pre-op planning. This does require a pre-op thin-cut CT scan in using the MDT robotics platform. You can also do an intra-op O-arm spin, but the usual workflow is either as an outpatient or an inpatient prior to surgery. Patients do get a thin-cut CT scan, and this is an image of what the software looks like, which is something that I'll be going over a little bit later in this talk. The planning software allows you the ability to execute exactly what you have in mind. And so with this, the software serves as this repository, as this note keeper as you look over your pre-op imaging. All of you prior to any surgery will be looking over your x-rays and CTs and MRIs, and you look and you scan and you take a look at where the small pedicles are and where the curves are, and then you go to bed or you go to your office, and then you show up the next day, you walk in the OR, and you remember, hopefully, most of it. The software captures all of that because the software makes you plan your implants in advance. And so with this, there is no winging it. There is no eyeballing it. The software demands that you have to be precise in your exact thought and plan because in the software, you determine the diameter of your screw, the length of your screw, your entry point, your trajectory. All of this is determined up front because the software has to know that to direct the robotic arm to help you execute your own plan. And this is pre-op planning versus intra-op doing. Now, the workflow comparison that I like to show is essentially with intra-op doing, navigation, fluoro assist, or freehand. You again review your x-rays and your MRI, you show up in the OR, and then you just do. You spin your CT, you bring in the C-arm, and then you either nav or fluoro assist or freehand all your implants. You troubleshoot as needed. You check your first assist implants as needed. And then all of the time is just this undetermined on-the-fly work, which should hopefully be fairly short if the workflow is good, but in those rare instances can take up this large amount of time. Now for pre-op planning, there is this upfront investment in pre-op planning with the Mazor X software. But once that is done, all you do is show up in the OR, the techs set up the robot, and then there is an accurate and precise placement of implants based on your set plan. And as I've shown here, that saves, or rather can potentially save, valuable OR time, which is arguably one of the most valuable commodities in a hospital system. With this pre-op planning software, that means that when you've already gone over the software and you've looked over your own patient's CT, like I mentioned earlier, you've already determined the entry points, the trajectories, the screw diameter and the length. And because you're looking at your patient's CT scan, you're already reviewing pitfalls such as large facets, small pedicles, scoliotic curves, or revision pitfalls such as fusion mass, prior trajectories, or implants that are in your way. All of this is being reviewed as you look at it. You develop the plan, you put into the robot, and now the robotic arm will assist you in helping you execute what your plan is. The best analogy I can refer it to is essentially like bowling. In intra-op doing, navigation, fluoro assist, freehand, you have the bowling ball, you have the lane, and you roll it down the lane, and usually you'll get there. Sometimes you'll be a little bit off. You'll get that strike, most of the time, hopefully. Every once in a while, rarely, you have to troubleshoot and check where your errors are in the OR, on the fly, in real time. Pre-op planning, the analogy is that the Mazor X software sets you those lanes because you have this upfront investment in looking at what the ideal trajectories and entry points are based off of what you want. That way, this allows you each and every time to be accurate and precise in what plan you want to execute for your patient. Now here again, once you put in the plan into the arm comes down, sets you on where your entry point is, and if this is the level of interest, once that arm is in place, it is fixed and rigid, and everything goes down the arm, especially with the Stealth Edition, where now everything goes down that effector arm, including the drill, the tap, and the screw, and then you move on to the next level. So you can see how with this upfront investment in the planning, you have systemized the rest of your implantation of your instruments for the entirety of the case. So the million-dollar question is, how long then does pre-op planning take? And I'm so glad you asked, because that leads me into the final section, which is the Mazor X software. So shown here is going to be a software demo on an L45 minimally invasive posterior spinal fusion, so I'm planning 4 screws at 2 levels. Now this video is only 2 minutes long. That being said, it's been sped up double time, which means that in its entirety, it took me less than 5 minutes to plan this instrumentation. So again, you log in, you pick out your patient, you mark out where you want the robot to focus on with regards to the levels of the spine. The software then auto-segments this, and you can check it to make sure that it is what you want it to do. You pick your level, and then it labels everything else in the spine. And once that's done, you go to this planning screen where at the L4 level, you can see I am literally deciding my implant. You can take a look at the bottom of the screen here, right? 6.5x40 screw on the left side and the right side, and I'm deciding exactly where I want my entry point and my trajectory. Once that's done, I can scroll through the slices, just like a post-op CT scan, to make sure that there's no breaches. When I do that, you can see here, there's the potential for a superior and lateral breach. So then based off of this axial planning of the entry point trajectory, I then go on the sagittal, I bring down the entry point, and I aim the trajectory up. So you can see how here what I mean, there is no way that you cannot be precise in your plan because the software demands it. In this way, there's no winging it, there's no eyeballing it. You have to tell the software exactly what you want so that you can execute the best plan that you can. You can see here I moved on to the next level at L5. I'm upsizing my implants because that's what I want. 7.5x40 at L5. And again, I'm choosing, again, my entry point and my trajectory first on the axial screen. I will scroll through the slices. You can see all the screws are in bone. I go on the sagittals. The entire screw is in bone, right and left. And on a coronal again, the entire screw is in bone. So once I'm satisfied with this, then I move on to the summary details, and you can see this is my construct. I can zoom in, make sure that it looks appropriate, but since this is a minimally invasive application, I can also add towers. So now I can make sure that my incision planning at the skin makes sense. I can scroll through that and make sure that they're appropriate and intuitive for what I want to do with my patient. And in scrolling through, I can also, again, have that last check as if it's a post-op CT scan, that my screws would be all in bone on both, on all of those screens. And so again, this is in what would be the final construct. 2-minute video in real time, less than 5 minutes. Once that is done and loaded up into the robotic arm, this is an example of what happens. When you're in the OR and you send the arm comes down. Shown here is the system where K-wires are used. With the Stealth Edition, everything goes down that arm. But here's the skin incision. The blunt trocar goes down with the cannula. The cannula is then replaced with the drill guide, and then the drill goes down the drill guide, and a reduction tube goes in. This is, again, the K-wire system. With the newer system in the Stealth Edition, the arm would essentially then stay in place as you put down your tap and as you put down your screw. But you can see here, again, with 5 minutes of upfront planning, all of that on-the-fly, real-time, intra-op doing has now been removed from the OR time. And each step has now been systemized to allow you to essentially put in your implants and then carry on with the rest of your surgery and all the rest of the surgical